Okay, good afternoon. Hi, everybody. I'm Dr. Krishna Narasimhan. I'm the president and board chair for Doctors for America. And I'm absolutely thrilled to open this session of Advocacy Grand Rounds. Thank you all for attending. The purpose of this Advocacy Grand Rounds series is to provide you, the 20,000 plus physicians, medical trainees, and other healthcare professionals who are part of Doctors for America. We're trying to provide you with monthly training and courses that really help you with your day-to-day advocacy efforts. We've modeled it around the clinical grand rounds that we all know. Sometimes we love, but it's something that we know that's built into our clinical training, and just like that, we think health advocacy work has to be built in to the training that we all need. We also think it's a great opportunity for everyone to connect with others who are doing health advocacy work that interests them. So encourage everyone to send future events to your friends and colleagues, to partner organizations. And if you've got suggestions for future topics that you'd like to see or speakers you'd like to hear, please send those to us. So today we're doing a session at 1 p.m. and at 8 p.m. so that we can maximize the opportunity for everyone to attend. And we'll have recordings and other materials available afterwards. So I think today's topic is tremendously important. It's so timely and honestly practical. It's dismantling racism in your daily practice. And we're incredibly grateful to have Kelly Butler moderate this session, and Dr. Aletha Maybank, who comes back as our keynote speaker. And I'll just tell you personally, I'm so thrilled I got to moderate a session with Dr. Maybank, the anti-racism plenary at our National Leadership Conference. And that was just an amazing session, and learned so much. And I know the DFA membership was just continues still to this day talk about that session. So I know you're in for a treat, and really we're all going to learn a lot. So let me introduce our moderator. So future doctor to be in 1 month, Kelly Butler is a fourth year student. And since I'm at Howard, and I've been at Howard faculty for 15 years, super thrilled that she graduated from Howard University and has continued to go on to do great things. But she's about to graduate from the University of California, Irvine School of Medicine. She's originally from Los Angeles, but she has absolutely committed herself to serving marginalized communities throughout her career. She's an active member in various causes dedicated to students and professionals of color, working on issues like substance abuse disorder and addiction, homelessness, and a variety of other issues. She finished a Master's of Public Health and Health Policy at the Harvard T.H. Chan School of Public Health. Even while in that program, she led organizing efforts in juvenile justice reform, prison divestment. She completed a fellowship in equity, diversity, and inclusion. She increased civic engagement on campus and oversaw a workshop series on imposter syndrome. After she finished her master's, she went on to serve rural and frontier communities in Oregon on an opioid response team. And all this before starting a residency, which is going to be at UCSF in family medicine. So, super thrilled to have Kelly with us and to bring her passion to the forefront in this discussion with Dr. Maybank on this really important topic. So I'm going to hand it over to you, Kelly. Thanks again, and I can't wait to hear the discussion.
Thanks for that introduction. So I wanted to welcome you all. Welcome to this Advocacy Grand Rounds. First, to lay a couple ground rules about what we can expect or how we can move through this session. If you feel discomfort at any point, take the time you need to digest that discomfort and ask questions. We encourage it. Not everyone necessarily feels as comfortable speaking on these topics or thinking about these topics, but this is the place to start to learn. The second thing is there's no such thing as a stupid question. Ask the question if you have it. Third, to be aware of impact over intent in terms of statements or questions raised. And lastly, this is a first step for some and a continuing education opportunity for others. Be mindful of your stage or journey in learning to be anti-racist in practice. I first want to offer a quick poll for folks. Where are you coming from? Is this your first time joining us for an Advocacy Grand Rounds? How comfortable might you feel talking about race and racism? And lastly, are you aware of what we'll be talking about today in the American Medical Association's efforts to embed racial justice and advance health equity? Tell us. We'd love to hear. And while you're doing that, I'm proud to introduce our speaker for today, Dr. Aletha Maybank. She currently serves as the Chief Health Equity Officer and Senior Vice President for the American Medical Association, or AMA, where she focused on embedding health equity across all the work of the AMA, and leading the Center for Health Equity. She joined the AMA in April 2019 as their inaugural Chief Health Equity Officer. Dr. Maybank previously served as founding director for the Center for Health Equity at the New York City Department of Health and Mental Hygiene in 2014, and the Office of Minority Health in the Suffolk County Department of Health Services in 2006. She is a nationally recognized speaker, writer, and advisor on issues related to health equity, the future of medicine, and public health impact. That's how she joins us to this space today, and I'm proud to welcome you, Dr. Maybank.
Thank you. Would you like me to start, or are you going to give the results of the poll first?
Let's give the results of our poll.
Okay.
And I'm interested to see that most of us are coming from the East Coast. This is a first time joining an Advocacy Grand Rounds with DFA. Welcome to those who it's a first time, and welcome back for those who it's not. It's nice to see that most people report an answer of true in saying that they feel comfortable talking about how race and racism affects their learning environment or practice. And about 2/3 of us say that they're aware of the AMA's efforts that you'll be addressing today. So that's exciting to know. Thank you for participating in our poll. Take it away, Dr. Maybank.
All right, great. So I'm going to share my screen here. All right. There we go. Okay, awesome. So you can hear me, you can see me, everything's good. Okay, great. Good to be with you all again today, and you know, with Doctors for America for several years, have very close friends who are very engaged and have been engaged with Doctors for America from very beginning. And it's good to see and hear, or at least read, that 2/3 of folks who are on the call now or about, you know, have heard some of our efforts as related to equity and racial equity. And the reason why it's good is because we actually only formally launched, and this is going to be kind of a new introduction, but we just formally launched our strategic plan to embed equity 2 days ago for the AMA. So you all are kind of getting kind of one of a fresh kind of look at it. You know, we've shared it a lot and tried to share it widely, but we haven't been able to go in depth with a lot of people. So it's really awesome to have this opportunity today. And as our strategic plan actually opens up, and I think, you know, it's kind of practice now in terms of equity, is just making sure that we are acknowledging land and labor and the history of that within our country, and the people who have been affected and burdened by the realities of colonization and white supremacy, and how that has impacted health, but also to really celebrate the resilience and strength of Indigenous peoples and descendants of Africa to this day. And the work that I do, and I really completely believe this, and have been really thinking a lot about this in terms of the work that I do, and just really honoring the legacy that has come before me, and the legacy that I have, from my sense, a responsibility to still carry forward in doing this work. I wouldn't be here without all of the generations of people who really fought to open doors for myself and many others. So we're now in this time, right? Or we've been in this time of COVID for a while. And there was always a lot of conversation around, you know, prior to COVID, you know, actually about the digital transformation. You know, we were very slow moving in this country around telehealth, telemedicine, and then COVID comes around, and like everyone's doing telehealth, telemedicine, and it's the way of being now. And I would say COVID-19 also has done the same thing for the context of racism. And it's not only just COVID-19 and exposing the inequities, but it's really, I think, the public murder of George Floyd that really propelled our nation in talking about racism in a way that they have never talked about. To hear at a presidential inauguration, a president actually saying the words racism from the speech was just something completely new for this country. And we know that, many folks, and I'll get this in a second, have made declarations, but I think just important, and this is just foundational. I've talked about this, you've seen this in my deck before if you've seen my presentations, but just the grounding of what racism is in a system of power and oppression that structures opportunities and assigns value upon people and based on their skin color and disadvantaging people of color and advantaging whites. And I think it's just important to always ground and important to always recognize that our country has really been under the umbrella of colonization and structured oppression for more of its history than not. And so it's not fully a surprise that we are in the moment that we are in, but it's also speaks to how long this work and the trajectory of this work and the length of time that it will take for us to really build systems of equity and equality, but we need to start at this point. And there's plenty of evidence. I'm no longer at the point of, providing, the context of, does racism impact health? There's plenty of evidence and empirical evidence that demonstrates that. This is just one of the pieces from a few years ago from one of my mentors, Dr. Bassett, who put forward the piece of structural racism and health inequities and really being a fundamental cause. And structural racism shows up in almost every single system of our country, in almost most laws and policies that exist. And they all have the downstream effect of affecting people's health very directly. And it's across generations. And it actually can impact people from the time they're young all the way up until they're older. And the stress actually can also change the shape of our genes and increases our cortisol levels so that it leads to lots of inflammation in the body and eventually infection as well as inflammation as well as damage, in the body as well, and leading to health inequities that we know exist. So what we've now seen, in the last year, this is from the American Public Health Association. They have been doing a good job of collecting data across the country to see what public health entities and also kind of localities and governance bodies have been declaring racism as a public health issue. I think the last one is actually up to about 194 or so across the country. So people are stating it, they're naming it, which is really important. That was an important step for pushing us to this point. But it's the question is, what do we do? Now that we're at this point, even us at the AMA, at the point of where there was the murder of George Floyd during the summer, our board came together and pledged that we were going to do all that we could do to dismantle racism within the context of our healthcare system. And then in the fall, our House of Delegates actually passed policy, so it's formal within our structure of AMA to name and act on racism as a threat, a public health threat, to rid our healthcare system of racial essentialism, basically recognizing that race is a social and not a biological construct, and supporting the elimination of race as a proxy for ancestry, genetics, biology, in medical education, research, and clinical practice. So this is our stance as AMA, and so it actually opened the door for the way that I could do work, the way that I can talk about the work at the AMA that is pretty straightforward from my perspective. We've published several pieces, again, lots of declaration, and it's good. I'm not downplaying the importance of naming and for institutions to name public health or to name racism as a public health crisis. But again, it's what are those actions that we actually need to do to make sure that it's going to become embedded. I mean, on March 1st, we know the United States National Institutes of Health actually announced, that they're going to do lots of work around structural racism and biomedical research. On April 8th, the CDC, for the very first time, declared racism as a public health threat, which is huge. And so I think a lot of this work, from my perspective, and this is my third time starting kind of an office or a center of this type is, the importance of declaring and doing the work and externally naming, but also the importance of looking inward. And I'll talk about some of that in the deck. And then the importance of actual advocacy as well. And I think advocacy happens clearly in our own lives as individuals, in our families. Advocacy happens at the institutional level, and advocacy happens within society, at large. And we have to figure out what are the ways of which we can engage in each of those moments. What some of the advocacy that, we've recently done, myself, Dr. Nancy Krieger, who many of you are familiar with, probably Dr. Rhea Boyd as well, and Dr. Fernando de Mayo, who was on my team at the Center for Health Equity, took our time after, and it really was after a JAMA incident, which I'll talk about in a second, of which there was a conversation between two white male physicians on structural racism that really didn't have expertise on racism. And it caused us to really think about and look a little bit deeper into what our medical journal is really doing. We've kind of talked about it and said, we don't see a lot of publications on racism, or we don't see the word racism in medical journals. In social science and public health journals, we do see that, but we don't see that so much in medical journals. And so we took a look at the top 4 medical journals in the world and found that really they almost never publish scientific articles with the name racism really as a driver of poor health outcomes. And so we did see over the year 2020, as was expected, that there was a dramatic increase in the number of articles, with racism, but the vast majority were really commentaries or viewpoints, not really empirical studies that were featured or published. And when you looked at over more than 200,000 of the articles that were published in the last 30 years across the 4 major medical journals on the right, towards the right side, less than 1% actually included the word racism anywhere in the text. And among the few articles that did, upwards of 90% were predominantly opinion pieces, as I mentioned before, not scientific investigations. And this is really, it's problematic because typically we're a field of science who really looks poorly upon anecdotal evidence as really the least rigorous and most untrustworthy, but around the space of racism, we don't have much empirical evidence as well. And so, this is a bigger problem, especially when nearly most of what we do in medicine is really rooted in the evidence that we have, whether it's recommendations, whether it's to inform public policy or to set health guidelines or to adjust any kind of budgets or prioritize the nation's research agenda and determine medical standards in care. We use evidence. And if we don't have evidence about the impacts of racism on health outcomes, then we have a tremendous gap in what we are understanding about people and communities across this country. And as we move forward to this, in doing this work around racism, and this is a piece that was published by Dr. Lance Gravely, who wrote this remarkable piece about how whiteness works as it related to this JAMA podcast that I mentioned before. And I think critical to the article and what really struck me, and even in doing this work for the last couple of years, is how I actually feel racism is the important part to name, of course. It's a system of oppression, of course. But we also need to start shifting towards how are we naming white supremacy and white patriarchy in its role and its impact in other forms of oppression as well, but also as it relates to racism. And so I think we need to not only begin more explicitly understanding the impacts of racism on health, but also the impacts of white supremacy, itself on health as well. Sorry about that. And understanding even more deeply the roots and the connections and context of colonization and its formations of supremacy and the roots of capitalism in this country, and the existence of racial capitalism and how capitalism really is built upon, was built upon cheap labor, free labor, really, and the grabbing of land and genocide of people, and how this translates to trauma and inflammation down the line and across generations. Very important for us to start to critically look at. Doing this work, at an institutional level, and I'm going to get a little bit more into our strategies into it in a second, but I think this is an important part, is that we can talk about the technical pieces of how do you operationalize racial justice work at an institutional level, but we also have to make sure that we're understanding what are these values or narratives oftentimes, or dominant or malignant narratives actually, that prevent us from moving forward and really undermine the advancement of health equity. And so Kamara Jones, Dr. Kamara Jones, who many of you know, a legend in the space, really talks very specifically about these 7 value targets that and myths that really undermine our advancement of health equity. And so I encourage folks, and you can see the list here, to really look into that. You can look up the article and read more about it, but to really start challenging this into the conversations that you have, whether they're in your advocacy space or in your institutional space, and see how they show up and how they completely can disrupt what you're trying to do in terms of advancing equity. And so I think our roles, as physicians and as institutions, again, naming and calling out white supremacy, racism, and other ideologies and systems of oppression, absolutely critical. Also, but making visible, not just in mere descriptive inequities, but how they operate and how these systems harm. And really concentrating on power. We don't talk enough about power. These conversations really are rooted in who has power to make decisions and who does not, who has power to distribute resources and who does not, who has the power connected to wealth. And so we need to ask deeper and more critical questions. And then also, how do we inspire power in those who are holding power to really think differently beyond their own self-interests and experiences, and actually to really, really care about what is happening. So this is our cover for our strategic plan that was released 2 days ago. And we took a lot of time to make sure that we were able to bring the medical community along. I come from public health. I'm not saying public health by far is perfect at all in terms of as a field and space, in terms of kind of embedding principles of social justice and racial justice. They are a little further along in my experience. And so we really wanted to take the time that if somebody picked it up, that we weren't going to put forward terms that some of them I just mentioned that they had never heard before, and then they weren't going to be able to understand them. And then they were going to put down the document. And so in the document, we take the time to even explain why we're doing a land and labor acknowledgement, and really putting forward our vision of not only just for us as the AMA and our role in it and our influence, but also our role and influence as it relates to changing and influencing the healthcare community overall. And then it shifts into a primer and really laying out terms such as racism and structural violence, and really defining them so that folks could better really understand the context of health inequities and health equity overall. And then we go into our strategies and our ways that we're going to be moving forward to do this work. And so we have 5 strategic approaches. One is, the first is embedding equity, which I'll talk about in a second, building alliances and sharing power, ensuring equity and innovation, pushing upstream, and fostering truth, reconciliation, and healing. And also in the document, we make sure that we wanted to share kind of what our theories of change are, and what righting the injustices of our past, challenging the dominant and malignant narratives that I've already mentioned, centering the voices and ideas of those who are most marginalized in any space, making sure that we're using a race and approach. We're leading with race and racism. We think that's absolutely important. Our data shows that we should, because of the way the inequities show out. But also it's the part that's least likely to be discussed and talked about, at least prior to COVID, that's for sure. And it's the area that makes people most uncomfortable rather. And we want to work on embracing public health frameworks and acting upstream. And the last one is an inside-outside strategy that I'll talk about in a second. So the embed part, this is the inside-outside strategy. The reality is, if we don't change ourselves, inside of the AMA, it is really hard for us to lead on the outside, and really hard for us to influence others as it relates to equity. And so the first strategy of embedding equity throughout the AMA and the culture and system and practices is really, how are we helping AMA's capacity? And when I say that, I mean our team. We have a team of 1,100 staff members who's worked on behalf of the 270,000 members of the AMA, and we're responsible for executing on policy. So if we don't understand, inequities and how they show up and how they're defined how, if we're not able to challenge our own mental models of how we come to this work on a day-to-day basis, we're not going to influence equity in the external environment or community at all. It's going to land, it's going to fall short. And we're making sure that we have like a trauma-informed lens to this work because it's very hard. And you have the risk of re-traumatizing people, and we'll assess our change over time. This is just one of our logic models for change, you know, just starting on the left, you know, again, the inside of the institution. And this is, there's nothing nuanced about this when you go from institution to institution, really. We all have, you know, workforce capacity, leadership capacity, data collection capacity, budgets and contracting. The reality is that we have to work to embed equity in all of those areas. We at the AMA are going to use our assets, which are the levers of change, to help drive and amplify these changes that we do. And hopefully then in the short term, we're able to influence culture and change culture practices, our research, evaluation, and policies. We can contribute to the understanding and advances in the field of health equity. We can address social and structural drivers of health and inequities, and then even confront the root causes of inequities with the long-term goal of improving health outcomes and closing the gaps. Understanding there are many folks and many institutions and society at large, you know, that have to be a part of this solution. We as AMA, we're very clear that it is not us alone who is a part of improving these long-term goals. And there's going to be a lot of learning and evaluation over time of this. This is the internal model that I was just mentioning from before. This is taken from Race Forward, and they're one of the largest racial justice institutes in the country. And it's just the model of normalize, organize, operationalize. This is something that our teams can wrap their minds around on how we're going to do this work. And so normalizing is like where all of the training pieces kind of happen. And we all know training alone is never sufficient enough. The data shows that. We're very clear about that. You have to operate at the level of the institution and its structures as well, and the level of culture as well at the institution. And so how we organize our teams and how we identify champions, disseminate information, have feedback loops, very important in order to move this work forward. And then operationalize, what are the tools and the data that we're going to use to show progress and to show gaps, very important. And as I mentioned, wrapped around it are the trauma and healing supports for the institution to be able to move forward. I'm not going to go through this in great detail. The one thing I'll just say is that, you know, before this, we didn't have a value of equity, but we did add our value of equity. And we focused on really centering the voices and ideas of those most marginalized in the work that we do. So it's not just the physicians that we work with, but also our teams and our staff and employees, that their voices are centered is really critical to this work. To build, you know, building alliances is again really focusing on how are we having structures and processes at the institutional level to center the voices and ideas of physicians, especially in this space. And then how are we working across groups such as the National Medical Association, or with the National Medical Association, the National Hispanic Medical Association, and many other groups to have more collective opportunity and collective action and advocacy to move this work forward, and not us have like top-down approaches to doing our work. And this is just one of our examples. This is more downstream and more programmatic, but it's it capitalizes on one of our pillars on improving health outcomes at the AMA, and specifically around high blood pressure. And we launched the Release the Pressure campaign, which is in partnership with the National Medical Association and the Association of Black Cardiologists. And we as AMA early on, you know, made a decision that, you know, financially we're in a good place. And so we understand that the expertise and the strength and the power that National Medical Association and Association of Black Cardiologists bring is really their expertise and their experience and their relationships. And so we're trying to find ways to shift power so that we can all come together in a way that doesn't burden or tax any of our partner groups, so that, you know, they can't participate, or we're kind of excluding and not recognizing all and the realities that they have to work through and face. And so this is just one of our campaigns. It's releasethepressure.org. We're using it in many different ways to pull people in. Push, and so pushing upstream, moving upstream, right? Most of healthcare operates on this bottom left side of population health and management. And our goal is to kind of work towards moving healthcare. This work has started happening. We do hear lots of language around social determinants of health, and at least, and I think it's not used quite accurately. There's a lot of work that's happening, or more work that's happening around social needs and providing social needs, which is more downstream. Social determinants of health is really working more so at the neighborhood level or at the community level. And so we actually now have an investment program at the neighborhood level as AMA. I'll mention it in a second. And then also, how do we use our advocacy power to really address the structures and the policies that impact justice and equity? And so our goal in all of this is really to strengthen physicians' knowledge of public health and structural and social drivers of inequities, empower physicians and health systems to dismantle structural racism, and equip physicians and health systems to improve services and technology. And in the strategic plan, there's a whole bunch of actions that are related to help doing this. Part of it is our educational hub, so that we have modules that are available. We've been working with AAMC to put forward standards and competencies. So there's a lot of work happening there. We've just launched, well, we just finished reviewing applications, I should say, for our Medical Justice and Advocacy Fellow. This is the first time we're doing this to really identify physicians. We need more physician leaders, and there are many within DFA, but as you know, we need more. And physician leaders that are doing advocacy and justice. And so we're going to announce those who have been chosen at some point in July. This is a partnership with the Satcher Health Leadership Institute, and really building upon Daniel Dahl's book, The Political Determinants of Health, who he is now the executive director of the Satcher Health Leadership Institute. And then we've been working with AAP, so American Academy of Pediatrics, along with several other physician associations to help support women physician leaders and women physician leaders in supporting their leadership and equity skills as well. And so we have 5 folks who have been chosen in our cohort, and that program is about to be launched as well. And then we are part of, also in terms of just thinking about upstream, we have partnered with 5 healthcare anchor institutions within the city of Chicago, where headquarters is located, to do social impact investing in the neighborhood of West Side, to really focus on the things that are on the bottom left of this slide. And so we're working towards measuring it. And this is a partnership that's led by community, it's driven by community residents, but also in partnership with the health department and the mayor's office and other healthcare providers. So we've had some really good opportunities as COVID came along to really find ways to actually respond really rapidly based on the structure of this partnership. Ensuring equitable opportunities and innovation. I received lots of outreach when I first started from innovators of color or folks who just had ideas or solutions that they had started, but no access to, or limited access or difficult access, I should say, to like venture or capital or any kind of way to kind of move the idea forward, and understanding that innovation is really important in the healthcare space, very important to AMA. We thought that this was an important area that we need to invest our time and energy in as the AMA and really work on embedding equity. We're at the very beginning of doing a lot of this work. And so to help kind of push us forward in a meaningful direction, you know, we've launched an external equity and innovation advisory group with some really awesome leaders across the country at the intersection of equity and innovation that are informing our direction. So soon we will have a plan of exactly what we're doing with that as well. And then lastly, fostering. So fostering pathways for truth, reconciliation, and healing. And the reality is that most historically white institutions have some level of a relationship with their communities, the neighborhoods that they rest in, that probably was harmful to some degree. And so we need to look at our own institution's history and our practices. And within the document of the strategic plan, not only are these listed, but a number are listed of some of our practices that were absolutely not advancing equity and actually quite harmful. And I think that's an absolute important part of doing this work. And how do we quantify it, which I'll get into in a second. But you know, the goal is to also work a lot to make visible the narratives that have been not visible, and to quantify these effects, and to make decisions on what do we do to repair the impacts of the harm that we have had. And so we do talk about this as well in the strategic plan. We have issued an apology as AMA in 2008 to the National Medical Association. And this was only just the beginning. This was Ron Davis, but this was specifically just for the exclusion of Black physicians for almost 100 years. But we haven't apologized quite for other things yet. We have started to do some actions, and our own CEO, Jim Madera, the current CEO of AMA, read a piece that was actually published jointly by the National Medical Association and JAMA, not JAMA, but the National Medical Association and the American Medical Association in the early 2000s. And after he read the piece and really saw the role that Nathan Davis, and the explicit role that Nathan Davis, considered the father of AMA, had on really determining that we were going to exclude Black physicians, he removed the archive from public view and removed the bust of Nathan Davis from public view and put it in the archives. And then also his name was removed from the award. And we actually have removed all names from awards just to prevent any further harm. So there's more work. This is just, these are steps. It's not enough. And there's more work that we have to do. We have to look at the impact of Flexner that was commissioned by AMA's Council of Medical Education, funded by the Carnegie Foundation, and just really better understand, again, the impact of shutting down 5 of the 7 Black med schools at that time, at the same time of excluding Black physicians, which prevented them from getting hospital privileges as well. And then we have other markers, and this is also in the list of, our former president, J. Marion Sims, and which was really highlighted in the book Medical Apartheid by Harriet Washington, who performed procedures on enslaved women without anesthesia, vaginal procedures without anesthesia, for the sake of innovation, and innovation that's still used to this day. And so what do we do with that history? How do we really quantify and qualify those costs? And so, I think this is a part of the national conversation and movement as well. Is really the conversations not only about truth, reconciliation, and healing, but redress and also reparations. And we know that, there was appalling evidence of racism that's embodied in the disproportionate COVID-19 incidents and mortality for Black Americans specifically, but other Americans as well, we're sure. And so, we took on this challenge, these authors, which was totally honored to be engaged with, and published this piece in Social Science and Medicine in 2021. And we know that the causes of inequities are locked into a feedback loop of wealth, for sure, and historical and ongoing forms of discrimination will deprive the Black population it has of building assets and generational wealth. That's one of the founding, the big causal factors that we don't talk enough about as it relates to health. And really there hadn't been, up until now, you were looking at the potential health impacts of racial justice interventions, including reparations payments. So we looked and basically, we found that a program towards, Black and Black individuals would not only decrease COVID-19 for recipients of wealth distribution, the mitigating effects would also be distributed across racial groups, benefiting the population at large. And so there's more in terms of in the document and more in terms of like the methodology and everything. But this is, I think the important part to me of that piece is that this is a movement in the country. I think we have to be more explicit about, as institutions, what are we going to do to look at our past? How are we going to look at our past? How are we going to quantify the harm rather? And then what are we going to do about it to repair? I think that is the movement forward that we really need to focus on. And always in remembering this, and this has come up a lot for me in the last 3 months, especially as it related to the JAMA podcast and all the conversations that I've been in related to that. Is the tendency, especially for us in the medical field, to really over intellectualize harm, or to even just intellectualize harm and not remember these are people, these are families, these are hearts, these are spirits, these are souls, and like everyone else looking to love. And the amount of violence that this is upon the body, as this quote says, is something that we have to remember and really center at the forefront of this, along with the voices and the hearts and spirits of those who have been most marginalized and harmed, and not to over intellectualize this work and this problem at the end of the day. And this is Ida B. Wells, who always gets called to my spirit for some good reason, I'm sure. But just again, looking to my ancestors who have opened the door for me to be here. But you know, the way to right the wrongs is to turn the light of truth upon them. It's hard work. And as the future Dr. Butler said at the top of the show, you know, people, you may feel uncomfortable, you may have felt uncomfortable in me talking about some of the topics within this, but I just, there's no way, there's no path forward. There's not a good path forward, and not a healthy path forward, a productive path forward, a just path forward if we don't turn the light on the truth and be courageous to do so at all moments of our work, within our institutions, within our homes, and with the larger society, if we're truly, truly interested and invested in doing equity and justice work. Thank you.
We thank you, Dr. Maybank, for bringing some really important points to light today. As you think about questions that you might want to pose to Dr. Maybank, I want to invite you to hear a couple of summarizing points to ground us in what's been addressed today. First, and not coming as any surprise, especially to the majority of participants here with us today, we know that racism impacts health, and that fact isn't new. It shows up in nearly every major system in our country, and we know that there are direct correlations between racism, chronic stress, and poor health outcomes. It's really powerful that the AMA's House of Delegates passed policy naming racism as a public health threat, because it hadn't before. And that sentiment has been put into action through the Center for Health Equity, led by Dr. Maybank. I want to reevaluate some of the key actions and strategies outlined in their strategic plan. First, it offers very clear definitions for common terms used in anti-racist discourse. And so if you're new to this conversation, that's okay. This is a resource for you too. It illustrates the historical context from which this plan was made necessary. And third, it has concise approaches, strategies, and theories of change. To reiterate some of those is first, aiming to embed racial and social justice throughout the AMA enterprise, all of its culture, systems, policies, and practice, and then specifically evaluating that change over time. Second, visualize, loudly and proudly centering equity, particularly among the most marginalized voices within the AMA. Third, to building alliances and sharing power with outside entities that have historically been left out. I think that's really important because at its founding, Dr. Maybank and I wouldn't have been allowed to be members of the organization that we're now fighting to change. Fourth, moving upstream in terms of addressing root causes of poor health outcomes among communities and populations. It may mean affecting policy, healthcare practices, the use of technology, reconfiguring payment. And I see a question that was brought up at that point specifically, and other social drivers of inequities. It also means supporting the work of individual physicians. And I'm looking forward to seeing and hearing about those fellows that have come forth through these various fellowship initiatives in the AMA. Fifth, ensuring equitable access to being innovative and being the change makers in innovation. And sixth, fostering pathways for truth, reconciliation, and healing. You made a beautiful point that acknowledging the racist and exclusionary history of the AMA is necessary in order to move forward. I think we can all pull examples of what these different steps might look like in our individual institutions. We don't mean this to necessarily be a model for you to exactly replicate, but it certainly can inspire this type of change in your individual institutions of academia, of group practice, in hospital systems, etc. You can aim to embed racial and social justice. You can loudly and proudly visualize equity. You can build alliances outside of your institution. You can move upstream in your institution. You can ensure equitable access to innovation, and you can foster a knowledge base and historical context and understanding of what your institution might have done to cause harm in the past. That is a power that all of you have in joining us today. So in hearing some of those summarizing points, I want to bring us to a place of questions. I want to invite you to ask questions either in our chat box or using the Q&A feature. But our first comes from Catherine. They ask if you can comment on how the AMA might be using their considerable political contribution war chest, specifically the Political Action Committee of the AMA, with equity as a core value.
Yes, I mean, thanks for the question. And so I almost want to take it as a statement. Yes, AMA can use their considerable power in that space to make sure that equity is a core value. I say that because, again, the plan was just launched. So there's a lot of work that we still have to do. And I think the first part of it is just even in releasing the plan and naming it so that folks understand and know our position. This is our formal position as AMA, and it's very different. I'm very clear about that. I'm so clear that this is not a document that folks would have expected from the AMA. So you can imagine also that means, as with any institution, and AMA is a national organization, it is a pretty, I have to give it to some level, I say democratic just because in watching the House of Delegates, understanding there's representation across all states, and we're very clear as elections play out, all states don't agree, right? But right now we're in the space where there are enough House of Delegates who are more supportive of equity and are pushing these equity policies and opportunities. But there's still a large part of education as it relates to, bringing the entire organization on board. I'm just being very real about that because I think that is true. And I get asked that question. And I don't want to put anything out there to say that, I don't see a reality about what is really here and what's existing at this time. My role is how are we strategic, in being able to, use, amplify, embed the voice and people of AMA and the membership to kind of move them along to advance equity, understanding there are many people who have been in AMA for years working to do this work and really working to push this organization in this direction. And I would say in the recent years, we have the Minority Affairs section that has been doing this for years. But in the recent years, especially our medical student section, they're the ones who have been really, they're then the ones, and you can just tell by the future Dr. Butler and just how she presented and summed up the summary before I came on and talked just now. But they're the ones who are really, they have the analysis, they have an understanding of these concepts, how it shows up, not only in the present time, but they actually have a sense of historically how we've gotten here. And so they have been very responsible for putting a lot of these resolutions forward that have opened the doors in this direction. And that's just, and I'm grateful because it helps with the work, but to the point of us being able to use our power in different ways, I think that's absolutely right. And I think we have to figure out our strategies around doing that. And so the charge to the teams now across AMA, our advocacy team, our like physician satisfaction or professional satisfaction teams, our marketing teams are now to kind of more so deeply figure out, so what are you going to do for your own business unit to operationalize this plan? What are the things that you can do to really embed equity into advocacy? And that takes work, again, because we have to do some level setting as it relates to training and building capacity of staff so that they understand the term, so that they can truly operationalize equity as a core value. So I just, there are so many steps into doing this. And I want to make sure that I'm very clear. It's not just we release the plan and all of a sudden AMA is going to show up this particular way. AMA showed up with this plan, and we're hoping it does, as Kelly said, it's going to inspire others to do the same and to push themselves as well. But we still have a lot of work to do as AMA behind this plan and to really put it into action and have accountability even more so.
I appreciate your humility, similar to Nimi in the chat box, just naming the elephant in the room, the socially and economically more conservative perspective that has been pervasive through the AMA and how it's going to take some real work for this sentiment to reach its individual cogs in the larger AMA wheel.
Yeah.
I think to specifically answer the question that Catherine posed, it's acknowledging that first you need that statement at the top. That has never happened before. And in order for an organization to move, an institution to move, its most powerful players at the top, and powerful I can even put in air quotes, must adopt this as a true sentiment before you can move towards specific action. And I think that's a really, really important point. A
And it
second
speaks to
question.
the next point in the chat, the other point in the chat around,
Mhm.
maybe you're about to read this.
Yeah, I'm gonna
I'm
get
sorry.
there. Yeah.
Go
So
ahead.
Pat specifically asks, in order to make this work, everything that's been outlined in the strategic plan a reality, won't it be necessary to address some of the major structural distortions in US medical care, specifically in how we fund care? They ask specifically, do we need to be moving towards a public, national, universal access system of care in order to rectify some of our larger racist and oppressive structures in medical care? I wonder what your thoughts or the thoughts of the AMA might be in this debate around national public medical insurance.
Yeah, so I mean, AMA is definitely supportive of universal care. You know, everyone should have care, and everyone should have access to insurance. Single payers, where historically everyone is very clear that AMA as an institution has not voted in support of that. Until prior to COVID, we were very close. The organization was very close to a different way. And so you'll see, I think, you know, again, the institution is evolving, and we'll see eventually over time how AMA lands in terms of advocacy and big advocacy as it relates to payment and structure. But it's absolutely right. I mean, this again, I just answer I'm in agreement. You know, I think it's absolutely right. There has to be a lot that changes as it relates to payment and structure, core values of an understanding, again, of what I mentioned at the top, in terms of around meritocracy and naming capitalism and its relationship, and racial capitalism and its relationship and setup and foundation of the healthcare system, and how that prevents us from advancing equity as well. And so I think, you know, it's what I value about this time, and that I've really tried to fully capitalize on, is just really being able to name, as Kelly said, because we weren't talking about any of this before. To say capitalism, to even have capitalism in the document, or even to say it in a conversation, was just not even happening. And so I think we're pushing, and I think that's the important part. While these doors open, I hope this document helps people push. It gives some folks some armor to kind of go with and say, look, you know, the AMA is saying this, the conservative organization even has this language at this time, and is starting to put forward these concepts that we need to strongly consider in this country, and how we evolve and develop and strengthen our healthcare system, and really our system of health overall. As mentioned, you know, I think it's just, that just needs to be different and better in how we bring public health and healthcare together, and all the narratives and challenges around that.
I think a follow-up in answering this question about where the AMA might fall in the national debate around single payer insurance or a national health insurance plan is also evaluating how the AMA leverages or addresses the influence of profit in medicine. Lee specifically asks, could you discuss further how the AMA will address how profit motives in medicine and our private insurance system that is rooted in racist capitalism and perpetuates racism and health inequities?
Yeah, as I just stated, I mean, so I think the part is that what I'm trying not to do, and I want to be very transparent about this, as I was before, is that not everyone in the AMA is at that point yet, right? And at that point of, we haven't figured out fully how to operationalize the plan. We have put a plan forward, we have put a vision forward, we have some actions and some key actions, but there's going to be a lot of work and conversations that need to happen in order for us to move really towards the lens of equity and justice. And so I could put forward ideas, but I will not do that, because then I'm stepping outside of the organization and doing that. Aletha Maybank has her ideas of how certain things should happen, of course. However, I'm respecting the ability And I guess the hope and faith that we are going to continue to move forward in advancing equity and justice. And that for us and for me, and it's an interesting point because, and I get it, and it's fair, you know, you put out a plan and people want more. They're like, you know, and it's not enough yet. And I get it, and we have to be held accountable. But this is where we're at. And I think we always have to recognize certain successes of where we're at. And to continually push forward. And then we also have to look internally, because the other thing that I see is, rightfully so, criticism of the AMA. I would never dispute that. Also, but many of us are working at historically white institutions that have the same issues. And they're just not elevated in the same way. And it's how are we going to start showing up as individual physicians or collective physicians within our institutions to help change those institutions. And I know there's perceived risk, of course, and real risk in doing so. And I'm sure there is risk for me, I would say somewhat as well. There's always risk for me in every conversation that I have because I tend to push a little bit. But I do feel that this is the time where we have to show up much more courageously than we had before. And this is the opportunity to do so. And this, hopefully this document helps you do so. Again, in your spaces, but we also all have to critically look in our own spaces.
I think there's a couple points here that you can extrapolate to your individual institutions, Lee, yours included. First is acknowledging that different people in your organization or institution will be at different stages in change in terms of adopting equity and justice as real lifestyles, right? And that in that, it's hard to just abolish systems that have been so deeply rooted in society, the capitalist system that you highlighted being one of them. I think there's a humility in acknowledging that fact. And then there's also an actionable point to acknowledging that fact, because unless you acknowledge and identify where in your institution there may be discrepancies in terms of moving towards this placed inequity, then you can't really move. And so first it's acknowledging, yes, profit does not necessarily align with best health outcomes. Profit can sometimes be a detriment to progress towards equity, and acknowledging that, and specifically in the foster piece of this strategic plan, is important. It's an important first step. Coming to our last question from Matthew, we really want to think about how people can embed some of what has been addressed today in their individual practice. Matthew asks, how does a clinic or hospital measure success when it comes to equity initiatives, particularly since so many of the variables seem largely determined upstream?
Yeah, that's a great question. And so some of the work under the pushing upstream that doesn't, we'll come more forward with this, but we are getting ready to work and really push more around the ability for healthcare systems, especially hospitals and other smaller systems, to be utilizing their their quality and safety parts to embed equity. As many of us know, equity, while it was part of the quality framework, often historically was just not even paid attention to, and not much was done around, and especially not racial equity. And so we are now starting to build a body of work, and hopefully we'll be able to launch it a little bit later this year and also early next year to help support institutions in doing just that. One, how do you use your quality and safety systems to strengthen the equity work that wouldn't just impact clearly that system, but also just what the work of that institution is doing overall, but also being able to measure it through that system as well. And so we have, some expertise that are now on board that come from the Brighams. Our Dr. Karthik Sivasankar, who is now my VP of Equitable Health Systems, is really an expert in this space. And so we are looking to launch cohorts with healthcare institutions across the country to help support them in having a collective opportunity for them to learn how to do that, but also figure out how to measure and also create more measurement tools, because there aren't not enough measurement tools to do that. So what's being highlighted is an absolute gap, and we're looking to try to fill that over the next 2 years.
I want to thank you, Dr. Maybank, for your frank honesty and for your vulnerability and acknowledging some of the faults, gaps, missteps of the organization in the past, and then offering some real tangible solutions about how this organization will be moving. I want to encourage everyone to continue to engage in conversations like this one. Your work doesn't have to stop or start here. There are a couple different pieces that I want to highlight that have been dropped in our chat box today. First, we really want to understand what you got out of this talk today. Complete our survey and let us know how we can improve in the future. We're also holding this session again at 8 p.m. Eastern, and so if there are others that you think might want to join us, then do that. We'll be having a very similar conversation this evening. The conversation around Advocacy Grand Rounds doesn't stop here either. There are a number of sessions on June 10th at the same times, 1 p.m. and 8 p.m. that you can join us for to continue this conversation about how you can put some of these sentiments and thoughts into action and practice. So join us on June 10th and you can register at the link in our chat. In terms of assessment models or how other institutions might be approaching some of this work, Doctors for America has also put together an anti-racism toolkit, complete with information from various academic hospital systems, clinics, etc., around what they've done on their campuses. Because again, we heard a very specific framework from the American Medical Association today, but there are many ways to approach this work. This is one of them. And we want to encourage you to do that investigative work. That toolkit has also been dropped in the chat box. And if you have questions around the creation or resources that are highlighted in that toolkit, by all means forward them to us within the DFA. Again, we want to thank you, Dr. Maybank, for being with us today. And I want to thank all of our attendees for taking the time to critically evaluate their own contributions to this larger push towards equity and anti-racism. Thanks for joining us, and we'll see you all this evening.
Thank you.